guys, I'm Jana. I'll be your nurse today. I was ordered to do a full head-to-toe assessment on you. Can you please state your name and date of birth?
Cristel Suarez, February 23, 2001.
Okay, so that matches our records. I'm gonna go ahead and give you privacy, so thank you. Before I start, do you have any questions regarding the procedure?
No.
Okay, I want to be touching certain areas of the body, so if I could have your information in advance.
Yes.
Okay, so I'm gonna go ahead and start, okay? So as I already evaluated the patient's response to me, she was able to talk to me. Go ahead and start with the head and scalp. Head is normal cephalic. There's no evidence of macrocephaly or microcephaly. Patient's face is symmetrical bilaterally. There's no evidence of facial drooping on one side or Bell's palsy. There's no evidence of pallor or paleness or masses or lesions. I'm going to palpate the scalp. Patient's scalp is smooth. There's no evidence of masses or lesions. There's no evidence of flaking or scaling or dandruff. There's no evidence of pediculi or lesions. And patients, as I look into patient's hair, it is distributed symmetrical bilaterally. There's no evidence of hair loss or alopecia. Patient's hair is thick and coarse. It is dark brown, consistent with the rest of her ethnicity. I'm going to go ahead and check behind the ear and at the nape of the neck. There's no evidence of pendicular or any excursions. Okay, I'm going to go ahead and palpate for your auricle. Do you feel any pain or tenderness there?
No.
Okay, tragus, do you feel any pain or tenderness?
No.
Okay, your mastoid process, do you feel any pain or tenderness?
No.
Okay, awesome. So I'm going to go ahead and come back to the front again, looking at the patient's eyebrows. It is symmetrical bilaterally. Hair is distributed symmetrical bilaterally. Eyelashes, hair distribution is also symmetrical bilaterally. The upper lashes go up and the lower lashes go down, and they slightly go outward. And there's no evidence of ptosis on the eyelids. Looking at the cornea is untransparent. Looking at the inner structures of the eye, the patient's iris is brown. It is consistent throughout her whole iris. Her pupil is within the normal range, 2 to 6 millimeters. Looking at the sclera, it is white. There's no evidence of yellowing for jaundice. I'm going to go ahead and look into your conjunctiva. It is pink and moist. There's no evidence of erythema or inflammation. Looking at the side, sclera is not protruding out, so there's no evidence of exophthalmos that's associated with hypothyroidism. Cornea, again, is transparent. There's no evidence of cloudiness related to glaucoma. So I'm going to go ahead and look into the ears. I have gathered my supplies with me right here as I've entered the patient's room. I'm going to hold the otoscope upside down. I'm going to use pretend the light. Pulling the ear upwards and backward, looking at the pearly tympanic membrane, it is pearly gray, shiny. There's no evidence of deviations or distension. There's no evidence of inflammation or redness. At the ear canal, there's minimal cerumen that's yellow and brown, consistent with patient's ethnicity. Cone of light on the right side is going to be at 5 o'clock, and it will be the left side will be at 7. So I'm going to go ahead and go back to the front. I'm going to patients. I'm going to be testing for patients' cranial nerves 3, 4, and 6. I'll go ahead and follow this object distant, and then I want you to follow it as it gets closer. Okay, patient's pupil dilates to farther distant objects, and it constricts as it gets closer. I'm going to go ahead and test for your 6 cardinal fields of gaze. Follow my pen light with your eyes, and as I'm doing this, there's no evidence of nystagmus. So cranial nerve 3, 4, and 6 is intact in that way. And I'm going to go ahead and shine for your corneal light reflex at the bridge of your nose. So corneal light reflex is symmetrical bilaterally. I don't need to do the cover the uncovered touch. So that's good. So I'm going to go ahead and test for the pupillary response. I'm going to go ahead and do this one. I'm going to shine, look far away, and look at me. Okay, so the pupil is constricts briskly to direct light. I'm going to go ahead and look far distant again. And look at me. Okay, and the other pupil on the left side constricts briskly and consensually to indirect light. So again, pupil are round, equal, and reactive and to light and accommodation. So that's good. So patients 3, 4, and cranial nerves 3, 4, and 6 are all intact. I'm going to move down to the nose. Patient's nose is midline. As I palpate, do you feel any pain or tenderness there?
No.
No? Okay, go ahead and chin up. I can see that with a pen light, there's no nasal deviation, perforations, no nasal polyps, no discharge or any redness, anything like that. So good. And go ahead and cover my nose. Breathe, other side. Okay, so I can see that both patients' nostrils are patent. Now moving on to the lips and the mouth. Patient's lips is pink. It is moist. There's no evidence of dryness, flaking, or any lesions or masses. There's a distinct border between the lips and the rest of the skin of the face. Again, patient's skin is warm to touch, and then patient's skin is consistent with the rest of the body, skin color. I'll go ahead and using the tongue depressor. You could say for me. When patient says the uvula retracts, so cranial nerves 9 and 10 are all intact. Looking inside, the oral mucosa is pink and moist. There's no evidence of candidiasis, and so everything is good. No inflammation. Tonsils are graded 2+. Okay, we're done with that. Okay, so I'm gonna test for the range of motion of your tongue. Go ahead and stick your tongue up and up and down, left and right. Okay, so patient's cranial nerve number 12 are all intact. I'm gonna go ahead and test for cranial nerve number 7. Raise your eyebrows, wrinkle your forehead, frown, and then puff your cheeks. Blow your whistle, purse your lips, and smile. Smile with teeth. Alrighty, so patient's cranial nerve number 7 is all intact. So I'm gonna go ahead and move down to the neck. It is it's midline. It is sitting right in the middle of the shoulder. Do you feel any pain or tenderness when I do this?
No.
Okay, I'm gonna pop you for the lymph nodes. They're non-palpable. And then again, there's no masses or lesions or vascular stuff. So I'm gonna be testing for your range of motions. If you could just tilt your hair forward, backward, chin to your ear, and then rotate, and then shrug your shoulders. This is all testing for the accessory cranial nerve number 11. Now I want you to shrug against my resistance. Okay, shrug against my resistance. Okay, so patient's muscle strength of her neck are all 5 out of 5. So again, cranial nerve number 11 are all intact. So I'm gonna go ahead and move down to your arms. I'm looking at the color. It is consistent. The color is consistent with the rest of the body. It is warm to touch. Looking at her fingers, her nails, there's no evidence of Bose lines or pitting. Looking at for capillary refill, it is within less than 2 seconds. And go ahead and do this for me. Okay, patient's nail bed is 160 degrees, so I can see the window. There's no evidence of clubbing. Now I'm gonna go ahead and test for skin turgor. Okay, there's no evidence of tenting, so patient's skin is elastic there. And I'm gonna go ahead and do this for me. Okay, I'm gonna be palpating for any crepitus there. There's no evidence of crepitus or cracking. Then go ahead and rapidly do this on your thing. Okay, now go ahead and do this. Testing for fine motor skills. Patient's able to. Did you feel any difficulty doing that?
No.
Okay, now go ahead and test my grip. Okay, you're strong, so 5 out of 5 for your strength. And then go ahead and make a box. Close your box. And close it some more, and then open the box. Open some more, and then with your fingers make a box. Close it, open it, and open it some more. So patient was able to do that. Did you feel any difficulty?
No.
Okay, now go ahead and do this and spread your fingers apart. Okay, so patient's muscle strength is 5 out of 5. And again, do this again for me. And against my resistance, so I want you to pull and push. Okay, patient is strong, 5 out of 5. So and then patient was able to do a full active range of motion right there. So I think that's all. And then I'm gonna go ahead and go back to the chest, patient's chest. I'm gonna go for the radial pulse actually. Radial pulse is brisk, it is 2+. I'm gonna go ahead this way. Okay, patient's breathing is eupnic, it's within the normal range. There's no evidence of dyspnea. Looking at the thorax, the color is even with consistent with the rest of the body. It is warm to touch. Looking at the AP diameter from the side and the front, it is 1 to 2. There's no evidence of barrel chest, pectus carinatum, or pectus excavatum. I'm going to go ahead for the costal vertebral angle. It's within less than 90 degrees, so that's good. Patient's chest rise and fall are even rate, a regular rhythm. And patients, I don't see any evidence of patient using accessory muscles or using a trap-up position to help with her breathing. I'm going to go ahead and auscultate for your breath sounds. Okay, using the diaphragm, I'm going to go in locations. As I tap it, can you please take a deep breath for me at the apex on the right side, apex on the left side, second intercostal space on the right side, second intercostal space on the left side, fourth intercostal space on the right side, fourth intercostal space on the left side, sixth intercostal space on the right side, second intercostal space, sixth intercostal space on the left side. So using the diaphragm, I was able to auscultate bronchial sounds in the upper area, and I moved down, I could hear bronchiovesicular sounds, and I go lateral to the sixth intercostal space, I could hear vesicular sounds. I'm going to go ahead and switch to the bell to listen for adventitious sounds. at the same locations I've stated before. Okay, second, and fourth, okay, and 6 intercostal. Again, I didn't hear any adventitious sounds, no crackles, no bronchi, no wheezings or rails. Now I'm going to go ahead and turn, if you could turn around to the back for me. Again, inspecting the patient's back, it is consistent with the rest of the body. It is symmetrical bilaterally. I'm going to go ahead and auscultate breath sounds with the diaphragm once again. I'm going to go ahead and start at the apex. Deep breath. Okay, bronchial sounds there. Okay, at the scapula, above the scapular ridge. Okay, bronchiovesicular sounds. Okay, base of the scapula, breathe. Okay, bronchiovesicular sounds, 6 intercostal space. Bronchiovesicular sounds, and I go to the 8th intercostal space. Vesicular sounds. Turn it to the bell, using the same areas for adventitious sounds. Okay. Base of the scapula. 6th intercostal space. 8th intercostal space. Okay, again, I wasn't able to auscultate any adventitious sounds, rails, wheezings, or bronchi. I'm going to go to the lateral now. Using the bell, if you could put your hips and hands on your waist. I'm going to start from the right side, or the forward. Okay, forward. Middle. Middle. And then forward. Backward. And then backward. I'm going to switch with the bell. Forward. Deep breath. Forward. Okay, middle. Middle. Forward. Backward. And then backward. Again, I was not able to auscultate any adventitious sounds, no bronchi, rails, or wheezing. Now I was able to hear vesicular sounds on the lateral side. So as I'm in the back, I'm going to go ahead and test for the whispers now. If you could cover your right ear and whisper what I said from 1 to 2 feet away. Popcorn.
Popcorn.
Okay, patient was cranial nerve number 8 is intact. So go ahead and I'm already in the back, so I'm just looking. If you could just lean forward. There's no evidence spinous in the middle, midline. There's no evidence of scoliosis, kyphosis, or lordosis. Do you feel any pain or tenderness as I palpate?
No.
No. Okay. Alrighty. So go ahead and face front again. Are you feeling comfortable?
Yes.
Okay. So I'm going to go ahead and auscultate for heart sounds, starting at the aortic on the right side, the 2nd intercostal space, midclavicular, and then opposite side would be the pulmonary, the diaphragm, and then 3rd intercostal space, midclavicular, on the left side would be Erb's point, and then 4th intercostal space would be the tricuspid. Okay, at the 6th for the mitral or bicuspid. Okay, everything is brisk, and it is everything is brisk. There's no evidence of abnormal heart sounds. There's no evidence of murmurs or bruits. Everything is good. I'm going to switch to my bell, listening for the aortic. Okay, I could hear S2 sounds loud here. There's no evidence of S3 or S4. At the pulmonic, I could not hear S1 or S2 or S4, no murmurs. Erb's point, again, no S1, S2 sounds. I couldn't hear any murmurs. Tricuspid. Okay, S1 sounds a little louder here. There's no evidence of sound S3, S4 or galloping or murmurs. And then at the mitral S1, I could hear slightly of S4 before S1 here. Okay, no murmurs. Okay. And I'm gonna go ahead and go back and palpate for the PMI at the 5th intercostal space, midclavicular line on the left side. Okay, so it is 2+ embrace. There's no evidence of heaves, thrills, or lifts. Okay, so everything is good there. And if you could go ahead and lay down for me, get comfortable. If you lift up your shirt, looking at the abdomen, inspecting it, the color is consistent with the rest of the body. The contour is flat. There's no evidence of visible peristalsis of pulsations. Okay, there's no evidence of any vascular lesions or distended or enlarged organs. I'm going to go ahead and auscultate for bowel sounds. Okay, starting with the right lower quadrant, right here. Okay, no more active bowel sounds. Right upper quadrant, no more active bowel sounds. Left lower quadrant, no more active bowel sounds. Left upper quadrant, no more active bowel sounds. Okay, as I auscultated for the bowel sounds, I could hear it within the 5-30 seconds intervals. And I could hear high-pitched gurgling sounds, and there's no evidence of any bruits or venous hums over the aorta or over above the epigastric region. There's no evidence of Berbergme sounds or anything that's abnormal. And then I'm gonna go ahead and do a light palpation. If you could tell me if you feel any pain. This is gonna be 1 to 2 centimeters. Okay, do you feel any pain?
No.
Okay, right upper quadrant, do you feel any pain?
No.
Do you feel any pain in left lower quadrant?
No.
Right upper quadrant, do you feel any pain?
No.
I'm gonna go ahead and do a deep palpation with 3 to 4 centimeters. Go ahead, do you feel any pain?
No.
Do you feel any pain?
No.
I could palpate some borders of the liver, but there's no evidence of liver enlargement. The right side?
No.
And then the spleen is non-palpable. Do you feel any pain here?
No.
Okay, so upon deep palpation, there's no evidence of rebound pain, any Murphy sign for appendicitis. Everything is good. Go ahead and put down your shirt. I'm going to go ahead and move down to patient's lower extremities. I could see that the leg is symmetrical bilaterally. There's no evidence of hair loss or uneven distribution of hair because it is even bilaterally. Patient's skin color is consistent with the rest of the body. It is warm against to touch. And then I'm looking for, there's no evidence of vascular veins, masses, or lesions. Checking for pitting edema for 3 seconds. Okay, there's no evidence of pitting edema. Moving down, I'm going to go ahead and palpate for your post-tibial pulse. Okay, it is 2+ and brisk, and your dorsal pedis. 2+ and brisk for the amplitude. Okay, I can see there's no evidence of ulcerations or wounds associated with venous and arterial insufficiency. Moving down to the toes, checking for capillary refill. It is within less than 2 seconds. Snail beds are within 160. It is pink, and there's no evidence of Bose line or pitting. There's no evidence of clubbing that's associated with chronic hypoxia. So you could go ahead and sit up right now, and if you can let your leg hang. I'm going to test for deep tendon reflex right here. Do you feel funny? Okay. Okay, so I'm going to grade that 2+, so the deep tendon reflex is intact. So if I could go ahead and stand up for me. Okay, rapidly tap the floor. Okay, do a figure 8. Alrighty, and then you could run your heel to your shin. Alrighty, if you could balance, I'm gonna go close to you, close your eyes and balance. Okay, hop into 1 foot, hop, hop, hop. Okay, and can you go ahead and close your eyes and touch your nose? Close it, okay, 4 times, and then close your eyes and, touch your nose and touch my finger. Okay, again, so patient's fine motor skills, again, intact, proprioception is all intact. And the patient was able to do movement. Did you have any difficulty during that?
No.
Okay, go ahead and walk towards me. Patient's gait is normal. Hands and feet are walking in tandem. Going back and you go heel to toe. Okay, patient was able to maintain her balance throughout that. And if you could go ahead and do this. Touch the floor. Again, I already checked for the spine was already symmetrical at the midline. There's no evidence of kyphosis, scoliosis, or lordosis. Go ahead and go to the back. And side to side. If you could rotate. Okay, do you feel any pain or tenderness to that? So
no.
Full active range of motions. So then go ahead and back in the bed. Okay, anything else, right? So that's everything from the head to toe. That's everything. I'm gonna put your head in lowest bench position. Side rails up. If this is your client, if you have any questions. And again, I'm gonna document and tell the doctor I've done it already. I'm gonna gather my supplies and clean up. Hand hygiene. And now if you have any questions, that's all for today. Thank you for your time. Okay.